Bismillah ar-Rahman ar-Rahim. This is Dr. Ahmed Hasan. I'm a cardiology consultant from Egypt. Today, inshallah, we are going to speak about device therapy in heart failure. As we all know, according to the European Society of Cardiology Guidelines 2021 for the diagnosis and treatment of acute and chronic heart failure, we have the four pillars for the therapy and the treatment of heart failure. They include the ACE inhibitors or ARNI, beta blockers, mineralocorticoid receptor antagonists, the sodium glucose transporter 2 inhibitors such as the dapagliflozin or the empagliflozin. These are the four pillars for medical therapy for heart failure with reduced ejection fraction HFrEF. According to the guidelines, if the patient still symptomatic and still is complaining of persistent heart failure manifestations and fulfilling certain specific criteria, the patient might be a candidate for a device therapy. These devices include either CRT or an ICD. Regarding the CRT, what's meant by CRT? CRT means cardiac resynchronization therapy. From its name, it means that its aim is to regain the synchronized biventricular contraction. So it will be suitable for a patient who is suffering from unsynchronized biventricular contraction, or those patients whose ventricles, right and the left ventricle, are not contracting in harmony or are not simultaneously contracting within each other's, simultaneous with each other's. Of course, this unsimultaneous biventricular contraction will lead to an optimum cardiac output and will lead to inefficient cardiac output and stroke volume, and thus the trials have proven that regaining this harmonic and synchronized biventricular contraction will lead to improvement of the LV systolic function and subsequent improvement of the cardiac output and subsequent improvement in the heart failure manifestations. The CRT components is composed of three leads connected to a device, a programmer, a device, or a pacemaker. These leads are connected to one of the leads is connected to the right ventricle, as we see here in this diagram, and the other lead is connected to the coronary sinus, which is the venous drainage of the heart that is lying in the atrioventricular groove in the posterior aspect between the left atrium and the left ventricle, and it will be extended to a certain distance in one of the tributaries of the coronary sinus that leads to activation of the left ventricle. So, upon programming of this CRT, CRT programming will lead to optimized biventricular pacing, simultaneous biventricular pacing, or simultaneous contraction of both the right ventricle and the left ventricle that will lead to subsequent improvement in the cardiac output and the ejection fraction and subsequent improvement of the heart failure manifestations. Of course, selected individuals and selected patients are going to get benefit from this device. Not all heart failure patients will get benefit from this device. So it's important to properly select those patients who might get benefit from the CRT. So now we are searching for those patients who haven't this kind of harmonic simultaneous biventricular contraction. How can I know? How can I get those patients? Those patients, I can know them from the surface ECG. The surface ECG is very important to properly select those patients who might benefit from the CRT and who are suffering from this kind of asynchronous and unharmonic biventricular contraction from the width of the QRS complex and the morphology of the QRS complex. Of course, if we have a white complex, this means that we have uh, a kind of intraventricular conduction delay, and we have that unsynchronized and unharmonic biventricular contraction. The studies have been proven that those patients with a left bundle branch block morphology and with a QRS width which is more than 150 millisecond, these are the subsets of patients who will get the maximum benefit from regaining the harmonic and the synchronized biventricular contraction. Of course, these left bundle branch block patients, uh, you can imagine with me that the impulse is going down from the SA node till the AV node and then the his bundle, and then going down through the his bundle, it will find the left bundle is blocked, so it will go down through the right bundle. The impulse will activate then the right ventricle at first, and then the left ventricle will be activated from the cell-to-cell myocardial transmission of this nerve impulse that will lead to subsequent left ventricular contraction. So the right ventricle is contracting milliseconds prior to the left ventricular contraction, and these are this is the hallmark of the unsynchronized biventricular contraction that leads to inefficient cardiac output. And this is why this machine tries to get this harmonic contraction. The patients who will get the maximum benefit are those with the marked interventricular conduction delay and those with left bundle branch block QRS morphology and a QRS width which is more than 150 milliseconds. So whenever you encounter a patient with a HAV-REF with an LV ejection fraction less than 35%, and who is on the maximum optimum medical therapy with the four pillars of anti-failure medications that we have mentioned prior at the first. And then they are still symptomatic from heart failure manifestations. And then you encounter in their ECG normal sinus rhythm and a QRS duration, which is more than 150 milliseconds in a left bundle branch block QRS morphology. So these patients are the optimum patients to be selected to insert a CRT who might get benefit from the CRT. Of course, if we have left bundle branch block, but with a narrower complex with a QRS width, which is from 130 to 149 milliseconds, they are still among the patients who might benefit from the CRT. However, to a lesser extent from the first group, according to the width of the QRS complex. If we encounter a patient with a markedly wide QRS width with more than 150 millisecond QRS width, however, with non-left bundle branch block QRS morphology still also this denotes that they have a kind of interventricular conduction delay and unharmonic and unsynchronized biventricular contraction, and those patients, they are also suitable candidates for CRT implantation. However, the beneficial effect might be lesser or might be to a lesser degree than those category with left bundle branch block and more than 150 milliseconds QRS width. Also, those with non-left bundle branch block QRS morphology and a width of 130 to 149 milliseconds, also they might get benefit, however, to a lesser extent, and this is why this is a class 2B indication for CRT implantation. Sometimes you encounter a patient with complete heart block who is indicated for permanent pacing. And when you do for him a bedside transthoracic echocardiography, you find that he has a heart failure with reduced ejection fraction and impaired LV systolic function. These patients, or these groups of patients, they might benefit from CRT implantation regardless of the width of the QRS complex and regardless of the Neuroheart Association function plus the RN. So instead of implanting a DDD, you might implant for them a CRT. So, uh, patients CRT, as we see in the class 3, is not recommended in those patients who are in heart failure with reduced ejection fraction less than 35%, and a QRS width which is less than 130 milliseconds. Those patients are not suitable candidates for CRT, and they are not fulfilling the criteria, and they will not get benefit from CRT implantation despite that they have ejection fraction less than 35%. Okay, this is the first device that we use for heart failure patients. There is another group of patients of heart failure who are candidates for an ICD implantation. What's the ICD? ICD from its name, from its abbreviation, implantable cardioverter defibrillator. This is a device, either single chamber or dual chamber ICD, has an RV shock lead. This RV shock lead is responsible for giving an internal defibrillatory shock whenever the patient passes into life-threatening, endangering, and lethal ventricular tachyarrhythmia, whether ventricular tachycardia or ventricular fibrillation. And this is why the indications for implantation of an ICD is either secondary prevention or primary prevention. Of course, the secondary prevention carries a class 1A indication. It's indicated for those patients who have sustained a prior sustained ventricular tachycardia, or if the patient is a survivor of sudden cardiac arrest, whether due to ventricular tachycardia or ventricular fibrillation. So the ischemic patient who is a survivor of sudden cardiac arrest, those patients with ischemic cardiomyopathies who are survivors of sudden cardiac arrest, they are a suitable candidates for an ICD as a secondary prevention to prevent or to deal with any possible future life-threatening ventricular tachyarrhythmia. So this is a secondary prevention indication. Of note, uh, there is an important note that should be mentioned that those patients, we should exclude the secondary reversible causes of ventricular tachyarrhythmia, such as electrolyte disturbances, any patient with drug-induced proarrhythmia, drug-induced long QT, and those with acute myocardial infarction. Of course, those patients might be electrically unstable within the first 48 hours after the acute myocardial infarction and may pass into ventricular tachyarrhythmia. Those patients should be excluded from the secondary prevention indications of ICD. Why? Because we have reversible cause that after correcting this reversible cause, the incidence of recurrence of the arrhythmia will be low. So this is an important condition. Important condition. the ICD indicate the ICD as a secondary prevention should be conditioned by exclusion of the reversible causes. Of course, if the ischemic cardiomyopathy patient sustained a life-threatening ventricular tachyarrhythmia after 48 hours from acute myocardial infarction, this mostly will be due to a scar in the infarction territory. So this patient is included in our indication for ICD. However, the exclusion should be timed by this 48 hours time period. Okay, what about the primary prevention? The primary prevention indication is due to the patients with ischemic cardiomyopathy with an LV ejection fraction less than 35%. Despite 3 months of optimal medical therapy, they are still symptomatic of heart failure, New York function class 2 to 3. Okay. However, without a prior documented ventricular tachyarrhythmia or without a prior sudden cardiac death from ventricular tachyarrhythmia. And this carries the primary prevention indication for an ICD. Why? Because this patient is a high-risk patient to sustain a future adverse events of ventricular life-threatening tachyarrhythmia. So as a primary prevention, this patient is included in the guidelines to insert an implantable cardioverter defibrillator, and the ischemic cardiomyopathy patient also should pass at least 40 days or should be evaluated at least 40 days post myocardial infarction to be in this category of patients who are candidates for a primary prevention of ICD. Then the ICD, as we can see here, is not recommended within 40 days of MI as implantation at this time doesn't improve the prognosis. And ICD is not recommended in patients with New York Heart Association function class 4 with severe comorbidities, with severe symptoms, with persistent heart failure manifestations refractory to pharmacological therapy, unless they are candidates for CRT or ventricular assist device or heart transplantation. Then, what about if the patient is not a suitable candidate for CRT or not a suitable candidate for ICD, whether primary or secondary prevention? This will lead us to the other category of patients who might get benefit from what's known by left ventricular assist device, a device that is responsible for improving the cardiac output and improving the ejection fraction. However, it's surgically implanted through a surgical operation. Those patients should have advanced heart failure and should be excluded from a CRT indication. So those are not suitable for CRT and not suitable for ICD, and they are now indicated for either left ventricular assist device or indicated for cardiac transplantation. Who are these patients? These patients who are in heart failure with severe and persistent symptoms of heart failure, function class 3 to 4, with an LV ejection fraction less than 30%. Those patients with episodes of pulmonary and systemic congestion requiring high doses of IV diuretics, or episodes of low cardiac output requiring positive inotropic supports or vasopressors, or those patients who sustain malignant tachyarrhythmias causing more than one unplanned visit or hospitalization in the last 1 year, or those with severe impairment of exercise capacity or inability to exercise, or have low 6-minute walking test. Again, if a patient has one of these characteristics, more than one admission in the prior 1 month or prior 1 year of heart failure or cardiogenic shock, those patients with prior inotropic use, those patients who are intolerant to either beta blockers or ARNI or renin-angiotensin-aldosterone system inhibitors, those with LV ejection fraction less than 20%, or those with marked comorbidities such as with worsening renal functions, worsening liver function, those with worsening right ventricular function, or those with malignant ventricular tachyarrhythmias or appropriate ICD shocks. or those with heart failure who need to escalate diuretic doses for persistent congestion, or those with signs of peripheral hyperperfusion and hypotension. If we have these kind of advanced heart failure patients, they should be referred to advanced heart failure center to see the suitability for either left ventricular assist device or heart transplantation. Okay, what about the indication of left ventricular assist device? At first, the patient should be excluded as a suitable candidate for CRT. So our patients uh, are not the subset of group of patients who might get benefit from a CRT. This is the first thing. The second thing, he should be in a severe persistence of severe symptoms despite optimal medical therapy. Okay, or even patients who have received a prior CRT, okay, but they are still symptomatic from advanced heart failure and persistent symptoms of heart failure despite the CRT. Then the second step is to see whether this patient is suitable and candidate for left ventricular assist device or not. Okay. Okay, what's the second? Second, the patient should not have severe right ventricular dysfunction or severe tricuspid regurgitation. This is very, very, very important because the patients who are candidates for left ventricular assist device, they are dependent on the right ventricular output. So whenever we have a patient with severe right ventricular dysfunction and with poor right ventricular cardiac output, they are not candidate for left ventricular assist device, as the left ventricular assist device depends on the right ventricular cardiac output from the right side. Okay? Okay. Also, we should exclude the major contraindications, and the major contraindications include psychological status. If the patient is psychologically unstable, because this is a major procedure, should be done for those patients with psychologically stable status. Okay, okay. If we excluded the contraindication of the patients with heart failure, if we excluded the contraindications for patients with left ventricular assist device, they should have also one of the following criteria. Number one, the patient should be having LV ejection fraction less than 25%. The patient should have more than 3 heart failure hospitalizations in the previous 1 year. The patient might be dependent on IV inotropic therapy or temporary mechanical circulatory support such as intra-aortic balloon. The patient should have a progressive worsening of renal and hepatic function. The patient might have type 2 pulmonary hypertension due to reduced perfusion and not to inadequately low ventricular filling pressures. The pulmonary capillary wedge pressure should be more than 20 millimeters mercury and the systolic blood pressure is less than 90 millimeters mercury, and the cardiac index should be less than 2 liters per minute per surface square meter. Okay. So the low ventricular filling pressure is a contraindication for LVAD. What's the low ventricular filling pressure? This is the left ventricular and diastolic pressure. The LVAD will get benefit for those patients with high left ventricular and diastolic pressure, namely those with pulmonary capillary wedge pressure more than 20 millimeters mercury. Of course, these criteria are measured by the invasive right heart catheterization. If we find those patients with advanced heart failure who might be a candidate for left ventricular assist device, then the specialized cardiac center will perform right heart catheterization to measure these left ventricular filling pressure status, the pulmonary capillary wedge pressure, and the volume status prior to label the patient to left ventricular assist device. Okay, What about the heart transplantation? The major indication of heart transplantation is that those patients with heart failure and those patients who are not suitable candidates for left ventricular assist device. So if the left ventricular assist device is contraindicated, so now the last resort for those sick patients is heart transplantation. And what are the contraindications for heart transplantation? The contraindications if the patient is in active infection, if the patient has severe peripheral arterial disease, if the patient has organic cerebrovascular insult or disease, if the patient has irreversible pulmonary hypertension, malignancy with poor prognosis, irreversible liver dysfunction, such as liver cirrhosis, or irreversible renal dysfunction, creatinine clearance less than 30 milliliters per minute per surface square meter. Those patients are not suitable candidates for heart transplantation. Also, those with systemic disease, with multi-organ dysfunction, those with severe comorbidities and poor prognosis, and if the body mass index is more than 35 kilograms per surface square meter, if the patients are psychologically unstable, that jeopardizes the proper follow-up, and if there's insufficient social support to achieve compliant care in the outpatient setting, so those patients are not candidate for heart transplantation as well. Thank you.